Hello, and welcome to this module, where we will use virtual reality and medical imaging to review a case on anti NMDA receptor encephalitis. My name is Megan Mazzata, and I am a fourth-year medical student at CU School of Medicine in this imaging elective. For a brief overview of our case, we have a patient who is 19 years old, a female, brought to the ED by her parents for 2 days of headache and low-grade fever. Her lab tests were done, showing normal white blood cells, a mildly elevated CRP, and she was sent home with medications for symptom management. 2 days later, she was brought back with worsening symptoms, as well as the addition of new onset dysarthria and aggressive behavior. For examination, her vitals were relatively stable, except for a fever of 100.5, and she had a slightly lower GCS due to slight confusion. For physical exam, and specifically mental status exam, she displayed aggressive behavior, dysarthric speech, disorganized thoughts, delusions, auditory hallucinations. She was oriented to person but not place or time. Otherwise, the exam was unremarkable. When we think about our approach, we start with differential diagnoses, and in this case, the first on the list was primary psychiatric disorder. However, given her fever, not everything fit, so we have to include viral encephalitis or encephalitis in general, neurologic malignancy, drug intoxications, and NMS. For a workup, imaging was done, including brain MRI with no abnormal findings. Repeat labs showed elevated white blood cells, that mildly elevated CRP, and significantly, CSF analysis showed lymphocytic pleocytosis and positive oligoclonal bands. On EEG, it was found to be epileptic activity. At this point, things were pointing towards autoimmune encephalitis, and given her demographics, specifically anti NMDA receptor encephalitis, so CSF was tested for anti-GLU N1 antibody levels, and a pelvic MRI looking for ovarian teratoma was ordered. And that is the image that we'll be taking a look at here. If we start with the 2D view of this pelvic MRI, we have the anterior patient, posterior, her left side and her right side. The MRI was done with and without contrast. And if we look to the radiologic findings before we get into our VR volumetric scan, we can see that her uterus is neutrally positioned right here. She has a normal endometrial stripe and junction zone thickness. There's no focal mass. Her vagina is within normal limits. You can't see it in this image. And her right ovary is normal. It's when we go to her left ovary, which is what we're looking at right here, we can see this heterogeneous mass measuring at most 12 centimeters, and it contains these cystic loculated components, which is really classic and characteristic of a teratoma. We can also see it has macroscopic fat, as evidenced by the fat saturated sequences and other heterogeneous enhancements. If we turn to our volumetric scan, we can first just look at the patient from the coronal view, meaning that we are anterior and looking towards posterior, and we can see some of these big vessels that are important when doing surgery, specifically for the removal of a teratoma such as this. We can see her common iliac branching into internal and external. And if we go out more superficially, we can see her inferior epigastrix on either side here, which are other surgical landmarks for pelvic surgery. If we then turn to a sagittal view, we can compare this patient's anatomy with normal anatomy. Let's take a look at normal anatomy first. From anterior to posterior, we have our pelvic bone, then our urethra leading up to the urinary bladder, next vagina leading up into the uterus, and finally the anal canal leading to rectum and sigmoid colon. The most posterior bony structure here is the coccyx. Now let's take a look at our patient and see if this all matches up. Moving in, we can begin to see some of these structures right here. Going even farther, we can see our pubic bone, urinary bladder, and urethra perhaps the vagina right here. We cannot see the uterus as it's being obstructed by this same loculated structure that we're seeing on this imaging here. And then you can see rectum, you can see coccyx, and you can see rectum leading up into sigmoid colon, and then more caudally you can see, or more towards the head you can see bowel. We can take another look in the axial view going inwards just to get a better idea of where this mass is positioned. We can see right here, bladder, and then our loculated cystic mass coming up right here. We can perhaps see the uterus and the endometrial stripe as we saw in the other image, and the rectum leading up into colon behind. So you might be asking, how does an ovarian teratoma lead to these psychiatric symptoms that we're seeing in this patient's presentation? Well, in this large mass, there's several types of tissue, including neural tissue, and our body will create autoantibodies to this tissue, which then through the blood go up to the brain and react with the NMDA receptor subunit that is primarily expressed in the hippocampus and the forebrain, leading to these psychiatric symptoms that we're seeing. And that's exactly what was happening in this patient. She was ultimately diagnosed with NMDA autoimmune encephalitis secondary to her ovarian teratoma. In terms of management, the first step was tumor resection. And then next she was treated with IV methylprednisolone, IVIG, and she ended up having improvement before 14 days, but if not, it's common to add rituximab to this regimen. For long-term treatment, patients are transferred over to a single-agent therapy for about 2 to 6 months, in addition to close monitoring for relapse, as it happens in 15 to 20% of cases. Options for single-agent therapy include oral glucocorticoids as a taper, monthly IV methylprednisolone, monthly IVIG, or a single course of rituximab. Wrapping up here, it's important to highlight some of the major red flags for NMDA encephalitis. The first is the rapid onset of at least 4 of these 6 major groups of symptoms, specifically the psychiatric symptoms, speech dysfunction, seizures, movement disorders, level of consciousness that's decreased from baseline, autonomic dysfunction, or central hypoventilation, in addition to at least one of the following lab results, of which our patient had both an abnormal EEG and CSF showing pleocytosis in oligoclonal bands. It's also important to exclude other diagnoses like the ones that we had in our differential from the beginning of the case, like primary psychiatric disorders, viral encephalitis, and malignancy. Thank you for listening. I hope you learned something about pelvic imaging as well as anti NMDA receptor encephalitis.